right, why don't we get started? Hi, everyone. I'm Nicole. I'm a continuing education coordinator for the Collaborative for Accountability and Improvement. And thank you for joining us for today's webinar, Who's Teaching the Future Generations About Open and Honest Communications? Please submit your questions into the chat or Q&A at any time. We look forward to hearing your thoughts. With that, I would like to introduce one of today's speakers, Dr. Dave Mayer. Dave is the founding executive director emeritus of MedStar Institute for Quality and Safety. In this role, he provides oversight and leadership for specific quality and safety programs in support of discovery, learning, and the application of innovative methods to operational clinical challenges. With clinical background in cardiac anesthesia, Dave is passionate about educating the next generations of physicians in patient safety. He founded and led the annual Telluride International Patient Safety Roundtable and Patient Safety Medical Student Summer Camp, as well as co-produced an award-winning educational film series on patient safety. And with that, Dave, I will hand it over to you for today's presentation.
Well, thank you, Nicole, and thanks to everybody for joining us today. We hope we make this a very engaging and stimulating conversation. Just quickly to review the learning objectives that were sent out, our goals today are to discuss the current state of curriculum in medical and nursing schools, residencies, and advanced training education around open and honest communication. Recognize the importance of teaching open and honest communication from one's early medical training and nursing training throughout their advanced career, and identify educational opportunities that we could all teach and continue to spread open and honest communication. A little bit more, I'm going to start off and just go over a little history of what's been going on, and then I will moderate the panelists and they'll introduce themselves. But over the last 20 years, I had the great pleasure of working with people like Tom Gallagher, Rick Boothman, Alan Kachelia, and so many others in efforts to make healthcare more transparent, and particularly around open and honest communication after preventable medical harm. I was also very proud to be part of a team at the University of Illinois, people like Tim McDonald, Kelly Smith, Bruce Lambert, and others that really embraced this type of approach and created what was called the 7 Pillars program that, along with other pioneers at the time, ended up coming together in what's now known as the Candor Toolkit. Many years ago, I was on a closing panel in Australia, a big safety meeting. I was tired, I was jet lagged, and I was a little frustrated that we hadn't been moving our quality metrics as well. And so I had the microphone in my hand, and one person went up to the microphone in the audience and said, in one sentence, I'd like all the panelists to share their thoughts on how we can make the world safer in healthcare. And without thinking, my mind just blurted out, educate the young and regulate the old. That sort of line has followed me. People always see me at meetings and they go, what's that line again? But I really believed, especially the first part, about that we needed to educate the young. There were people in aviation, Robert Helmreich and David Mewson, who spoke to the IOM, and they pushed healthcare to train safety at the beginning of nursing, pharmacy, medical school type initiatives and curriculum, because they say that's how you really start changing a culture. Well, I heard them talk and I was very impressed. And one of my roles at the University of Illinois was as the academic dean for the College of Medicine. So I thought, great, I'm going to try to implement a quality safety curriculum starting with the first-year medical students. And when I went to the literature, there was absolutely nothing out there that I could use as a basis for what needed to be taught and how it should be taught. So in 2005 and again in 2006, I pulled together a team of patient safety experts, educators, and patient and family advisors. And we all came together. Gwen and Carole were part of that group. And over 2 years, we came up with what we felt were the types of content that needed to be in a patient safety and healthcare safety curriculum. It also addressed what types of teaching modalities should be used: simulation, short answer, classroom, small group. And it talked about how to assess and evaluate the curriculum. We ended up publishing that in 2009. Little did we know at the same time the WHO was also doing work in Australia under Bruce Barraclough and Marilyn Walton. And 6 months after we published our work, they published their work, and the recommendations were exactly the same. Well, we decided we'd take that curriculum that we had developed, and in 2010, we were fortunate enough to get a small meeting grant award from AHRQ when we brought 25 medical nursing pharmacy students, resident physicians out to Telluride, Colorado. And you're looking at a number of people who taught that program. And it was so successful, we were able to get more funding and support after that first year. And through the gracious donations and contributions, over the last 12 years, we put 1,500 medical nursing pharmacy students and resident physicians through those programs. And we've also helped implement the curriculum in Sydney, Australia, and Doha, Qatar. So a lot of good stuff has been going on, and you're going to hear how this is beginning to spread. It's beginning to really move all across the healthcare spectrum. And as Nicole said, please put some questions in the chat box as we're going along. If you've been doing work in this area that you have something to share, please share it with us. We all want to learn. So we're going to start with our panelists now, and I'm going to pose a question to each one of them. But first, before they answer that question, I'd like them to introduce themselves and give their background. And I'll start with Gwen. Please introduce yourself, Gwen, and then I'll pose a question to you for discussion.
Okay. I'm Gwen Sherwood. I'm Professor Emeritus from the University of North Carolina at Chapel Hill. And I was in the co-leadership role of developing the Quality and Safety Education for Nursing, or QSIM project, with Linda Cronenwet, beginning in 2005, funded for 7 years by the Robert Wood Johnson Foundation. And that was nursing's response to the IOM Quality Chasm report on the healthcare professions education. We, as Dave mentioned, it's not just what we teach, but how we teach. So my work is led into a lot of work around pedagogy, reflective practice, as well as the interprofessional education domains. So I'll stop there and wait for your question.
Well, great. Thanks, Gwen. And just following up, QSIN has been such a powerful program for nurse education around quality and safety. And really, a lot of the other disciplines have not developed something as thorough for especially the next generation of nursing leaders. Share a little bit about QSIN, the type of work that gets done there, and how it's spread across the country in nursing schools.
Okay, thanks, Dave. QSIN, as I said, was our response to the IOM report on the essential competencies if we are to improve patient safety. They are patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. And since we're really focusing on open and honest communication, those competencies for communication are embedded and apply to each of the 6 competencies. But, if I had to really say that the real kernel of patient safety is teaching that open and honest communication, professional to professional, professional to patient, and so on. And so that has been the foundation of a lot of the QSIM work. We were able to get that approved by the different nursing accrediting bodies, so that from 2007, it has been required of all levels of nursing education to include those 6 competencies. And some of the projects that have spun off was a national project on just culture in schools of nursing and how we can model just culture and open and honest communication. And that work also, just let me quickly add, led into regional workshops so that we tried to reach as many nursing faculty as possible in a train-the-trainer model to be able to achieve spread. That work was so successful that in 2021, when the American Association for Colleges of Nursing that oversee curriculum did a new curriculum model, patient safety is integrated throughout the 10 domains, and communication is one of those. I also want to mention the interprofessional education for domains. Interprofessional communication is one of those. So I think we can, and nursing has been one of the professions to really adopt that. So I think that it is a really important concept. We just still need to do so much more.
Thank you, Gwen. That was great. Yeah, we've implemented some of that out in our Academy for Emerging Leaders and Patient Safety summer camps. It's such a great comprehensive program. I'll turn to Rachel now. Rachel, please introduce yourself.
Well, thank you so much for having me. It's my pleasure to be here. I'm Rachel Nash. I'm an internal medicine physician and current assistant professor of medicine at Cooper University Healthcare, which is located in Camden, New Jersey. And my current role is actually as the program director for the internal medicine residency program, the largest program at our institution with over 90 trainees pursuing their training in either primary care or categorical internal medicine.
Well, thank you. You've had the unique experience of being at our first Telluride Patient Safety Summer Camp, and then coming back and have been faculty with us in sharing your wisdom and knowledge with the future healthcare leaders. Could you share a little bit what it was like to get this sort of education very young in your career, and how it's helped you throughout as you continue to grow in your leadership roles?
Wow, I didn't know I was at the first one. That's pretty cool. Yeah, so that was almost 15 years ago now,
Yep.
but really was a transformative experience for me early in training. This was before I had even exposure to clinical medicine, before those clinical rotations. And it was such a breath of fresh air after, studying for 2 years, the biochemistry and every detail of the coagulation cascade. It was so great to be surrounded by other learners who just wanted to learn how to make patients safer in the care that we delivered. It just made sense. And the stories were the most powerful. And that's what I remember. And of course, we learn from those types of stories. So after that really transformative experience, being around such amazing educators and people who were willing to share some of these stories, I took that back to my medical school at the time, which was in Washington, D.C. at GW. And I just felt that my peers needed this same opportunity and this education that I was lucky enough to receive. So I planned an interclerkship day for all 180 of my fellow classmates and was able to do some near peer mentorship in some of these areas. And I even had Sorrel King, of course, who's Josie King's mom, able to visit our institution at the time. So really has changed the trajectory of my career. Now, here we are a decade later from that, and I'm in a leadership role where I get to teach trainees, the next generation of internal medicine physicians. And this material is still critical. It's communication skills. As much as our technology is advancing or artificial intelligence, we still need physicians who have the skills to sort through all of the data and to guide patients in our ever complex medical establishment and the system. So if I am lucky enough to share these skills and knowledge with the next generation, I believe that is my duty. So what I've been able to do as program director, and we'll talk about this as it relates to the ACGME and some of their requirements, but I get to send my trainees now to the summer camps, a few each year, and they come back with such incredible ideas and a way to pass this work forward. So I support their education through going through this same program, of course, but then support the initiatives when they return. So to actually answer your question, what it was like coming back as faculty, it was really an amazing experience. I was able to take now some real clinical experience, and we all have a story to tell because this work really is ongoing.
Well, thanks. I know the two residents this year put on a whole movie with Bleed Out and brought, you know, Steve and Margot Burrows in, and the university supported it. And, you know, another one of our patient and family members who teaches with us, Jack Gentry, refers to all these young future healthcare leaders as bumblebees. In fact, he gives out T-shirts with bumblebees on them to all the attendees because he wants them to go out and pollinate the world with these messages and learnings that they take out. And you're a great example, as well as those residents that come from Cooper every year are great examples of how they pay it forward and continue to teach it to others that didn't have that exposure, which is great. Carole, let me turn to you now. First, introduce yourself, and I've got a good question for you that I think will flow right from what Rachel has done.
Well, thank you. I appreciate the opportunity to be here today. Like so many of us on this call, we wear many different hats. So when I introduce myself, it's from 3 different roles that where I participate. One, I run the Executive Masters for Clinical Quality, Safety, and Leadership at Georgetown University. I am the Senior Director of Education at MedStar Health, and I am a co-founder of Patients for Patient Safety US. One of my probably primary roles is to be a patient activist. So Dave, with that, I'll let you pose your question to me.
Well, there you go. We just talked about the importance of patients, family members who've experienced healthcare either very well or unfortunately many times not so well. Can you talk about the role and why it's so important to have the patient or family member around the table, as we did in developing the curriculum and now teaching that curriculum to the future healthcare leaders?
Well, thank you for that. You know, I think all of us would agree that healthcare cannot solve these problems alone. You know, for the 20-some years they've tried, and we've learned to look at other outside industries. You know, many get tired of hearing the comparison to aviation or nuclear power, but the fact is we can pull nuggets in. Well, the same thing holds true for patients and families. One, because you can't do this work without them. You know, if they've been harmed, they oftentimes want to give back. But really what I like everyone to think about is just to think about what they can contribute besides their story. Their story is usually what gets them into this work, and it's very powerful and it connects the heart and the head. But patients and families have experiences and lives outside of this. So we've heard a running theme so far from Gwen and Dave and Rachel about communication. I'll just give you one example. My undergrad happens to be in the field of communication. When the Joint Commission used to report out year after year, they put out a graph, and for consistent years, the top 3 reasons for sentinel events were communication, leadership, and human factors. And year after year, the position would rotate. But the fact is, healthcare is about communication. It's about honesty, transparency, truthful telling. And patients and families help with that communication. They can help teach, like I've been fortunate enough to do. They can help after harm events by being involved in them, helping the organization to learn from them. What happens if you potentially have someone that's harmed that's a teacher? They can give back and give the organization their skill sets. How do you do good teaching? What is authentic teaching? What is case-based or problem-based learning? Say someone's an architect. They can give back and be like, you know what, this could be more efficient. So patients and families have a lot to contribute to any kind of education in healthcare from their own professional background and the experience with engaging in the healthcare system.
Fully agree. You know, Carole, you've heard and others have heard me say in many of my presentations that I've learned probably more from patients and family members about how to improve care and make it safer than I have many of my colleagues. And you know, I think a great example, many of you know Helen Haskell, her line where she says, patients and families see the whole movie. We just see, as clinicians or caregivers, we come in for 5 minutes, we see a snapshot or a little 1-minute screen of that movie, but they see the whole thing. And if they're not included, if they're not brought into the process of discovery and learning and being open and honest with them, we'll continue to make the same mistakes over and over again. Before we go to a few more questions, there's one in the chat box that I'll open up to our panelists. The question basically states, what happens if you're in a culture that hasn't progressed as far as it should in safety, and there's still a lot of fear of disclosure? How do you try to teach it, yet still keep people safe within that environment? I've always said, don't do this one-off unless you've got to have leadership support, or else you'll get buried in your hospital if you try to take on this alone. But I'll open it up to the three of you for comments of what could you do to introduce, or at least start a little bit of a movement in the right direction through education. Carole,
I think this is such a fascinating question. How difficult is this? I mean, you're really touching on culture, right? If you're in a culture that doesn't support this, it is very difficult. Culture is what drives behavior. And I think in HRO principles, that is the biggest thing. I wonder, something that I've tried to incorporate that I think trainees benefit from is admitting my own mistakes and sharing that maybe in the beginning of a rotation or beginning of the encounter can help the trainee see, I think, their superior, whoever, as vulnerable, right? And that we're all human and that we're in this together, and the patient has to be at the center. So if you're doing something that's in the benefit for the patient, I mean, that has to be your guiding light.
Yeah, great comment. Thank you.
I would add to that using story as well. And I'm going to sort of summarize Rachel as role modeling. And so I think there are two things. One, using story. And one of the things that we have done is use one of the really terrific stories that have been turned into movies. One that Dave has helped to produce, Tears to Transparency, the story of Louis Blackman, is a great way to get professions together and to be able to stimulate conversation. So that's one way, is using story. Our hospital used one of our faculty nearly died from sepsis, and so they developed a film around her experience to bring attention to sepsis. So I think story can be a very powerful teacher. From, as Carole pointed out, we have to engage patients in these conversations, and so sharing the story of their experiences can help to open attitudes. The other thing is to role model. I know one hospital, a unit, decided that they were going to begin to make some change, and they were able to implement team steps across their unit. They got administrative permission, but they were the only unit. Their outcomes were so terrific that then another unit wanted to mimic that, and another. And over about 2 years, it did spread across the hospital. So I think story and role modeling and never giving up, being true to the conversation.
Yeah.
So Gwen, I'll just add on to that, because I love how you said you've got to start small. That's just it. Sometimes we think we have to have it embedded across the whole organization, which is the goal. But sometimes it may be an event on a specific unit, and it may not be the catastrophic event, but something that the conversation starts and people can see that there's safety, there's psychological safety, there's learning that's going to come, that we can do this here. And as much as someone who's a harmed patient and family member, you want it everywhere, we realize that it sometimes has to build upon itself to change that culture in our organization. If you're not going to get it from leadership, it doesn't mean it can't happen. Sometimes we have to grow it from the bottom up to convince leadership and to make those small incremental changes to show that it can be done and move from unit to unit to unit sometimes. Not always the best way, but I don't ever like to give out hope that there's not a way that it can be done.
And we've had a couple, people post that they too believe in the power of stories, and it can change a conversation, and using those powerful way. I remember when we first started the 7 Pillars program, Tim McDonald is shared this story, and it was one of the most, amazing stories about being open and honest. We had a patient that unfortunately through a mistake got 2 doses of chemotherapy within 2.5 days. It was a tracking error, and she didn't know. She just thought it was the right thing, and she was so sick in the ICU for like 2 days. We were really concerned that she was going to survive, and fortunately she did. And when she got out of the ICU, the head of our hem-onc department was a naysayer about being open and honest, and Tim approached the physician and said, we've got to go talk to the woman and share that this is on us, and we need to confess, and we need to be apologetic and share. So he was resistant, but he went with Tim because Tim said, I'm going to do it whether you're with me or not. And they went through the whole story. They apologized. They said, this was our fault. We'll make sure and check so it won't happen again. She leans over to the doctor, calls him up closer, gives him a hug, and says, thank you. I thought that was a normal response to chemotherapy, and I was so sick I was going to go home and just die. But now I know it was a mistake, and you're going to make sure it doesn't happen again. I'm going to go through the therapy. And she went through it and became a 5-year survivor. So, he became, after that conversation, he became a believer. And when you change a naysayer at that high a level in an organization to a believer, people sort of flow with that change. And so, yeah, sometimes it's got to be small steps. And somebody put in, it's a great comment, you got to also talk about the smaller events that get people more comfortable in talking about our vulnerability. And like Rachel said, I made an error, and I talk about it when we were involved in a wrong-sided surgery case when I was a resident. And so those are powerful stories that could kind of move the masses. Carole, somebody mentioned about human factors, and you want to explain a little more?
Yeah, I'll clarify. So when the Joint Commission would put this out, it was not like human factors engineering. It was like human factors that contributed to the error. So when it was leadership, what they would attribute that to sometimes is there wasn't leadership support, or maybe policies or regulation. Communication could be anything from lack of communication breakdowns, handoffs. And then the human factors was that the human aspect involved in the error. So I hope that answered your question. And if you go to the Joint Commission website, it would oftentimes have more descriptors of what rolled up into those buckets.
Yeah, thanks, Carole. So Gwen, let me come back to you. You clearly are an expert on the importance of reflective practice, especially around safety and open and honest communication. You've published a book on the topic, and we embed a lot of that reflective practice into our week-long curriculum. Could you share the work you've done and why it's so important if we're going to make the changes we're all striving to?
Yes, this came, the emphasis on reflective practice came from out of the CUSM work when we had 15 schools and a pilot learning collaborative to trial ways that this could be embedded in nursing curricula. When we came back together after a year, almost every school mentioned the importance of reflective practice, teaching students how to be present and engage in an experience, and then at the end of the experience to ask themselves some honest questions about what just happened what went well, what needs to be improved going forward, and what are my lessons learned. There are multiple mnemonics that can be used to teach students how to embed that and help it to become a habit of the mind. Reflective practice is an essential skill for being able to change one's attitudes and behavior. And it is a lifelong practice, and it's a habit and a skill that needs to follow us our entire life, because it is how we make sense of experience. It is how we begin to be able to embrace and see other perspectives of the same event. It's how we can surface assumptions and biases that we have about how we respond, how we treat other people, and so therefore become aware of our own behavior and how we relate to other people. It's an essential skill for building interprofessional education and practice, so that we become aware of how we interact with other people within the healthcare team, to be able to recognize where we are a strength on the team and where we might need to improve our own behavior. We develop emotional intelligence through reflective practices in developing self-awareness, so that when we are in these difficult circumstances, we can be present in the moment and be aware and attuned to how is the patient reacting? How can I build my rapport with that patient? Or what is this other care member really reacting to? Are they angry with me, or are they just having a really tense day and their reaction actually has nothing to do with me? But I need to be open to the fact that we all are in this together. And I think it was Rachel who brought up the role of culture. Patient safety is so driven and so influenced. We could have an entire seminar on the role of culture in patient safety. Culture is are the behaviors and the attitudes that we allow to exist in our organizations and in our work. And we bring those to light and surface those and work on those through reflective practices.
That's great. And I know there was somebody that put in the chat for you, Gwen, that they started, were trained in how to do a log, and it was eye-opening to them, reflections and things. Another person, Kendra, is part of our faculty, talking about, having the daily safety huddle, what went right, which I think is really, we focus so many times on what went wrong, but we need to focus on what went right. We call them good catches in our organization, and celebrate when the system worked, when people use the tools and behaviors that we hope they would, and trap something before it reached the patient. We celebrate them. And I think, Kendra, it's a great comment moving forward. The other thing I love, Gwen, is we do it late afternoon, as you know. We break the students up and the residents into small groups. And then they each we take them to a picture in the lobby of the hotel. And they have to share their thoughts. And it's amazing to see the same picture, that people see so many different things that stick out from them. And they, come back in and they talk about seeing other people's perspectives. And it's clearly one of the highlights of their reflective practice with you. So it's a wonderful thing. Rachel, let's take it up to resident education now. We talked about some programs, but let's start getting into what the ACGME is doing. You're a program director. You embed this within your resident training, these important philosophies and principles. So share a little bit about the work with residents and how where ACG is trying to go with this, ACGME.
Absolutely. For those of you that don't know, the American College of Medical Physicians, or the College of Graduate Medical Education, requires any program that is accredited by the ACGME has to follow certain protocols. And of course, we are liable to the public for training physicians. We're the last checkpoint, if you will, until physicians are ready for independent or unsupervised practice. So there is a big regulatory burden, if you will, on programs. But I think the way that we translate that is we are held to certain requirements, and that is for patient safety and also quality improvement. So every trainee in any program, whether that's a fellowship or a core residency, their trainees have to be involved in a quality improvement project. So they have to identify a gap, a quality gap in care, and be involved in a project within their institution to improve the quality of care. So that helps us teach all of the elements of what creates quality of care, all of those 7 domains, and we have to teach our trainees how to work on and develop a project and keep some of those improvements going. On the patient safety aspect, the ACGME requires each resident to be involved in a patient safety activity related to a root cause analysis. And some program directors, let me tell you, are afraid of this. You know, they don't understand how they are going to fulfill this requirement, but actually it's quite simple. Anytime you review a case where something, a morbidity or mortality, some harm occurred, and you are looking at all of the systems factors, you know, using a fishbone diagram, for example, if you are participating in that type of learning activity with your trainees, that is fulfilling the requirement. So what we've seen, and I think most programs do this now, is a move away from that more traditional morbidity and mortality review or case conference, where it was really shame and blame of individuals, and moving towards a systems-based M&M or even health system science type of model, which is what we've adopted in our program as well. So those 2 elements are really what the ACGME is looking for: involvement in a root cause analysis type of activity. It could be real or even simulated, right? Even a discussion, for example, I know the Lewis Blackman case has come up several times. Even a discussion about that and the system factors would fulfill that requirement. And then involvement in quality improvement, where they have to look at a quality gap that exists, and often that pulls from errors that occur or near misses.
Yeah, it's really nice to see what the ACGME has done. And it wasn't that they just rolled this out without thinking about it or being pushed into it. You know, there's the accreditation side, which all the programs have to go through, that they've got to show specific things that the residents are involved in and progressing. But what they did with safety, and I've been fortunate to sit on that advisory board for the quality and safety side, is they would go and do site visits separately from the accreditation process, and they'd talk to everybody in the organization, from the president of the hospital to residents, wanting to know what they were doing to engage residents. And they'd verify it with residents in conversations there, no faculty or leadership were around. Now what they've learned and the things that they believe are important, like Rachel pointed out, are moving over to the accreditation side. And so they're going to have to show these things. And if they're not, they're to get put on probation like any other area of accreditation. So ACGME has done a nice job of raising the bar for resident education. I still think the AAMC is behind the 8 ball, so to speak, because there's been very little involvement, occasionally sometimes in a 3rd year or 4th year rotation. But resident or students do get, we help design some questions for the national boards part 3, but it's very superficial. I wish the medical arena had as much training as nursing and pharmacy does around teaching their young students about quality and safety. Carole, let's take it up a notch now. Let's talk about master's level and continuing learning degrees that are out there, both certificates and a full master's. You know the history of many of the programs. David Nash started one at Jefferson, Kevin Weiss at Northwestern. I have the the pleasure of getting one up and going at Illinois, but you're running it now. So at Georgetown, share a little bit about what's out there for those that want to get a higher degree education.
Yeah, so I think what is interesting is when we think about the impetus of patient safety and quality, it's not that old, right? We all go back to the IOM report, which will be 25 years old this year. We know that it's hard to change curriculum or get it infused in medical school, nursing, pharmacy, even in residence when it comes to patient safety. The one constant we can say is patient safety and quality is changing at a rapid speed. What we knew 25 years ago, a lot of it has vastly changed. And I think that's what leads us to advanced degree programs is, what you learned, if you learned anything in your early training, may not be the same kind of things now. And what we're seeing is that these mid-career learners that are getting into leadership roles in quality and safety are like, I don't have a good foundation. I was never really taught. I've heard about just culture. I've heard about human factors engineering, event reviews, how to disclose after harm. I just don't know enough about it. I don't know the literature. I don't know the theory. More importantly, I don't know how to apply it, right? We can read all of this, but what we want in patient safety and quality improvement is we want the actual application. And that's what a lot of the master's programs out there are teaching. There's about 13 what we call patient safety and quality master's programs. And these are different than your population health, than your health administration. It really is honing in on what we're talking about today. How do you change culture? Culture that improves safety and improves quality.
Yeah, it's important. And, getting that sort of advanced degree gives them that, I think, more confidence to be able to talk with leadership back at their hospital or health system about the importance of this work and showing them examples. There was a great comment put in the chat also about the ACGME Clear moving for a call of innovations that connect operational priorities at the health system to GME education. And CRP could be one of those innovations that is looked at, and how do you embed it in there? I'll tell you, one of the most powerful conferences I've seen, and it's done at a number of national meetings now, but we do it out in our academy's summer camps. We have a panel that's made up of just patients and family members who have been impacted by harm. We have Helen Haskell, Carole's on it, Steve and Margot Burrows, and Jack and Teresa Gentry, our usual panel members. And when they talk about the vast difference between getting absolutely no communication, no honesty, like the Burrows did, as was documented in the film Bleed Out, through the gamut of Helen's and then Carole's, and then to Jack Gentry's and Teresa Gentry's, where they talk about the positive impacts of what that open and honest conversation and coming together and trying to make things better as we move forward. The learners are just amazed. The questions never stop between that gamut of one extreme and the other. And then the little bit in the middle where they get a little bit of knowledge, but maybe not enough, or, Carol's where it took her a while before she had her questions answered. So that is a very powerful dynamic, using stories to push this forward and making it happen. Any other comments, thoughts by our panelists? We've opened it up to questions, and it's been great to see some of these coming in. But especially around the culture aspect that we touched on, and trying to get some movement going in those hospitals that are still pretty resistant to change.
Dave, I think there's in the Q&A, there's a question from Tom. I don't know if you saw that.
No, you want to read it? I might have missed that one.
Okay, Nicole, do you want to take it on?
Yeah, I was just going to bring that one up, so I'll go ahead and read that for you. Tom asks, at some organizations, risk management and litigation avoidance play an outsized role, sometimes diverting attention away from quality safety. Can the type of training you describe still take root in these types of organizations?
I'll jump in first, and then I hope everybody else will comment. It's challenging. It really is. You've got to have, I believe, an organization that's ready for it. When I went to MedStar, I was blessed to have the most amazing CEO, the amazing chief risk officer who just was doing this sort of open and honest, but it wasn't systemized across all our hospitals in our system. And it was easy. I'll be honest with you. It was difficult in rolling it out, but it was easy from my leadership standpoint. You get others that are still entrenched in delay, deny, and defend. And you could try to educate them and try to bring them along, but unless that C-suite and board is willing to listen to it, it's tough. Another thing that I'll mention, and I've said this, and it's not 100% true all the time, but I think it worked for me when I was looking at MedStar in particular. My first question is always, who does the chief risk officer report to? And again, it's not always 100%, but I find it a reliable indicator. If the chief risk officer in an organization reports up to the chief legal counsel, there's a good chance that that is not an organization that's embracing open and honest communication after harm. If the chief risk officer reports up to the chief medical officer, as it did here at the University of Illinois when I was there and at MedStar, I found those are learning organizations because the chief medical and the chief nursing officers and myself would sit with the chief risk officer and look at these cases and learn from them. And the only way you can learn from them is to be open and honest. Otherwise, you don't get the information to make the correct solutions you do. And so I was blessed in that environment that we really looked at every one of these cases from a learning opportunity, as well as what we needed to do to work with the patient and family and the care team that was involved. So I find, when students and residents especially are looking at where they're going for their first job or where they want to join a health system and a medical staff, that's one of the questions I tell them that they should ask, because if they go into an organization that it will just totally stop these type of initiatives, they're going to be frustrated. And many of them think that they could change the world when they leave and go on, and good for them. But so many of them just get depressed after trying to change an organization that doesn't want to change. I don't know, Gwen, any thoughts from the nursing side?
Yeah, this question is so related to the first question where we talked about trying to start without total administrative support. And while, don't not do anything if there's no system support. But one of the things that I love that Dave mentioned learning organizations, because that really is the hallmark. And one of the things that we haven't talked about, because we have such a short time today, are high reliability organizations that really have made that system and culture change into thinking about everything stems from how to avoid mistakes. But high reliability organizations also embrace a system-wide communication. We really feel like that you really do need from, we use the term C-suite, from the system leadership through housekeeping, through every department, to really have a high reliability organization that's really focused on open and honest communication, a just culture, and to really be able to operate from that standpoint of preventing patient harm. So I'm really glad this question came up. We used to talk about the difference from moving from a quality assurance approach to a quality improvement approach. And I think that's sort of inherent in those attitudes that David was alluding to. But this is a question that we really do need to spend a lot of time trying to understand some ways to work within that. I hope Carole and Rachel have some other thoughts to add to this.
Well, this is a really tough question, and perhaps what I would suggest is maybe leading with data in this situation, because the data shows that if you do have open and honest communication, and if you are upfront or apologize, you're actually saving money down the line because your risk of litigation is actually lower. And most people these days are concerned with the bottom line. So perhaps you could lead with some of that data. But it, you know, again, as folks have said, the culture is really paramount. I want to just maybe end these comments with one of the items in the chat about the ACGME and clear visit. I think that's totally on point. You have to involve trainees when you're thinking about institutional priorities, because there's this concept of the sharp edge, right? That pointy tip. And that's where the trainees are. They're at the bedside. They're spending more time with the patient than anyone in the C-suites that we've been talking about. So you have to involve the trainees in all of this if you really want to move the needle on any of those institutional priorities as it relates to safety.
I'll just conclude that I think risk management is evolving, right? It used to always be defend the organization. There's still many out there with that mindset, but I think we're seeing a new evolution of risk management, some even changing their names to try to be more on the proactive side, not the reactive, and proactive in supporting the patient and family, and not reactive and we have to protect the organization. Are we there yet? No. We have a lot of work to do in the risk management space. But you can see organizations like malpractice carriers like Beta and COPIC in different places trying to say, let's do this right. Let's put in programs. Let's take care of everyone throughout this process and not stop the communication, but actually elevate and enhance the communication.
Yeah. Carole, I'm glad you brought up Beta. They're doing great work out in California. And it touches on exactly what Rachel said. They're using data that has shown that if you embrace the 5 sort of tenets of the Candor Toolkit, they call it Beta Heart. If you embrace those 5 things, they're willing to give their hospitals discounts on medical malpractice premiums because they know it'll save everybody in the long run and improve the quality of care, which I think is a very unique, way of doing things to get people to roll the programs out, and they've been fairly successful in doing that. So it's solid. I know we're getting close to the end. We just got a couple minutes left. In regards to taking small steps, when we're out in Colorado and in Maryland, when we run these summer camps, we share with all the students and residents, you're not in a position yet where you could make a major change, but sometimes you could just do small little things. And we ask them on the last day to make a commitment to one thing that they're going to do when they get back. You heard Rachel's residents wanted to put on a conference and bring Steve and Margot Burrows in. Some do programs like that. But a 4th-year student made the commitment that she was going to Gwen's point in high reliability, she was going to introduce the safety moment. And so in her 4th year, she was one student that was picked, or 5 students that were picked to share their research program, given 10 minutes at a meeting that had about 300 physicians and nurse leaders in the room that were, rewarding them and recognizing the work they'd done. She started with a safety moment before she got into research, and she spent 45 seconds sharing a safety moment that she had heard and wanted to share it, and then got into her research presentation. She emailed me literally 3 days later and said, I had about 25 nursing and physician leaders come up and ask me, what's a safety moment and why did you use it? And she explained it. So it's a lot of things that, little things that even a student could do that raise awareness and create a discussion. And so we've seen that over and over again, and it's been a lot of fun. So I just want to thank Nicole and Tom and for allowing us to do this program today. Oh, Gwen, you had one last thing?
Yeah, there's a question in the Q&A that I would love for us to just quickly address, and it's about early learners and their fear of committing harm and what we can do. And just one quick response, if we're talking about new graduate nurses, all new graduate nurses should be in a guided preceptor program when they are transitioning from their academics to practice. And I'm not sure about physicians, but I just wanted to acknowledge that question so that we can think about that. It's such an important part of building a safety culture.
Yeah. Thanks, Gwen. I hadn't seen that one. But great interaction. I appreciate everybody who was attending, your feedback, your comments, your questions. It helped us shape the discussion. And to the panelists, thank you. And Nicole, you and Tom, keep up the great work, and have a great weekend.
Thank you, everyone. Thank you so much for joining us today, and a special thank you to our panelists for their time and sharing their insights and value. This webinar will be recorded and available on our YouTube channel if you want to share it with your colleagues who would find it valuable as well. And with that, everyone have a wonderful day, and we look forward to seeing you next time.
Thank you.
Thank you.
Thanks, everyone.